afternoon, I am Dr. Deblina and today we shall discuss regarding the role of ultrasound in congenital fetal infections. Okay, so we know that symptomatic infections because of viral or parasite, it affects around 5% of all pregnancies, but most of them are clinically silent. Okay. But the problem is that transplacental transmission of the infection in this some asymptomatic mother may also cause severe congenital infection. The problem is the clinical diagnosis is difficult because often the pre-pregnancy serology is not available, and when it is available it may be confusing in most cases, right? Now the pertinent question is routine screening for infection necessary in all pregnancies? As of now, universal screening is not recommended in pregnancy. Why? Because first of all, for most infection, there is no treatment available, even if we detect it. Secondly, there is high false positive rate for the markers, IgG or IgM, okay? And if it comes as positive, mostly it is because of any past infection. And when it comes as positive, it is we have to do invasive test, and there is risk for the fetus to detect the fetal infection, and a fetal infection does not warrant that the fetus will be affected. Means there may be fetal infection which may not affect the fetus, may not cause any congenital anomaly. Okay, so routine screening is not suggested as of now. Now, as an obstetrician, when do we encounter a congenital infection? Primarily when a mother have a exposure to any infectious person, any exposure to any infection, and she comes for an opinion. Secondly, she has already developed an infection since she is symptomatic now and she comes for an opinion. Or suppose she has a recurrent pregnancy loss, or for any other cause she had a screening test and that comes as positive and she presents to you. Or there is a sudden intrauterine demise which is not explained by any other pathology, any placental pathology or any other pathology. And finally, when you directly have a sonographical marker for fetal infection. So these are the scenarios when you will come face to face with fetal infection in pregnancies. Today we will first discuss regarding congenital toxoplasmosis. Just a basic knowledge about the life cycle of toxoplasma. The only known definitive host for toxoplasma is the feline, members of the feline class, okay, basically house cats. So they will shed oocyte in their feces, and the oocyte will take 1 to 4 days to sporulate and then become infective. They will contaminate the plant, the soil, water and vegetations. So now after ingestion of that, the cattle becomes infected, or the wild birds and rodents may become infected. Human primarily, in the infected cattle, these oocytes after ingestion will form tachys which forms tissue cyst and remains in the muscle. Now this human primarily become infected when they ingest this infected undercooked meat or unwashed vegetables, or they come in contact with contaminated soil or water. Rarely it may be because of any transplantations. It can be transferred because of organ transplantation or blood transfusion, rarely. Now the pertinent question today is for transplacental transmission once a pregnant woman is infected. Okay. So coming to the problem statement of toxoplasmosis. The problem is, first of all, there is no vaccine available for toxoplasmosis. So only 10% women in the pregnant childbearing age group are basically immune to toxoplasma because of a prior infection. The rest are non-immune. The incidence of toxoplasma has been seen in the pregnant age group to be around 2 to 5 per 1,000. Okay, and the risk of congenital toxoplasma is around 20 to 50% without treatment. So the mother is affected in 2 to 5 per 1,000. Of them, 20 to 50% will transmit this infection via placenta to the fetus. congenital toxoplasma only occurs because of a primary maternal infection. So infection can be primary, can be non-primary, like there is a recurrence of a infection because of a different strain, or a reactivation of a previous infection. This is more common with CMV, but this is not seen in toxoplasma. Toxoplasma is only primary infection, and only primary infection will cause infection of the fetus here. Another noteworthy thing is that if a maternal infection occurs prior to conception, that will usually not affect the fetus at all. Okay, so the fetus is safe in that case. Now, like most viral infections, the risk of congenital infection because of toxoplasma will increase with the increase in gestational age at which the mother was affected. Like in the first trimester, at if it occurs less than 4 weeks, then less than 1% is affected, and at 36 weeks, more than 60% is affected. But on the contrary, earlier the gestational age, more greater is the fetal severity of the fetal affection. So the incidence of fetal infection will increase with gestational age. Higher the gestational age, more will be the incidence of infection, but the severity is just opposite. Lesser the gestational age, more severe will be the infection. And 90% infected fetus who do not have a clinical sign at birth will develop sequelae later in life. That is one problem statement, okay? Because suppose we are seeing all UST findings normal, everything fine, but the baby may develop signs, sequelae of the long-term sequelae of the infection later in life. That poses a problem with the counseling of the patient. Now, what happens after the maternal infection? Mostly 2/3 are asymptomatic, only 1/3 are symptomatic, okay? And symptoms are similar to mild coryzal infection illness, which includes low-grade fever with malaise, headache, and there might be lymphadenopathy in some. How it is diagnosed? Diagnosis is by maternal serum IgG or IgM detection, okay? Basically, from this chart we can see that IgM will appear within the first month of the infection. It will reach the peak within the first month, and it will stay there for another month before coming down. But the problem with toxoplasma is the IgM might not come down after the second month. It may remain high for a very long time, and the IgG will also start increasing during the first month, but it will reach the peak during the 3rd month of infection, and thereafter, if untreated, it will maintain a plateau like that, okay? Now, these are the combinations we see in the report basically. So, you may have a IgG negative and a IgM negative. What does it indicate?
That she has never been affected by toxoplasmosis.
First, never been affected. Yes, susceptible to infection. Another is it's very early. She just have had a exposure. She's not seroconverted yet. That can be a possibility. Next, you may have a IgM positive and a IgG negative. That poses with a possibility of an acute infection, or it may be a false positive IgM because there are a lot of cross reactivities. Okay. So, one may be an acute reaction, one may be a false positive. How do we differentiate? We repeat the test after 2 weeks, 2 to 3 weeks basically. So, now if the titer is increasing, if we have the same value again, similar value, then it was probably a false positive test. But now if the titer is increasing 4-fold approximately, then it is an acute infection, okay? And we may have a IgM positive with a IgG equivocal. That is similar, it can be an acute infection. How do we differentiate? Now we do a IgG avidity test. Now what is avidity test? Avidity is the chance of binding of the antibody with the antigen. So the longer duration infection will have a higher chance of binding, okay? And early infection will have a lower chance of binding. So higher the avidity, older the infection, and lower the avidity, it's a recent infection. So this can be differentiated with the avidity test. Another scenario is when we have both positive, IgG positive, IgM positive. So again, it can be a IgG because of an old infection and a IgM which is false positive. Or it can be a new infection where the IgG is now rising. We differentiate again with the IgG avidity test over here, right? And also we can repeat after 4 weeks. If the IgM remains same, probably the IgM is a false positive, and the avidity test will of course tell us regarding the IgG values. So the cutoff for avidity is 30. Less than 30 indicates an acute infection within the last basically 3 months. More than 30 is above 3 months. Okay. Another point to be noted is when we get a serology positive in a pregnant woman with toxoplasma, we start with the spiromycin treatment. The spiromycin will delay the maturation of the IgG. So we may have low avidity for a very long time in those cases because the IgG are not matured enough. Okay. Now, what problem does it poses in the fetus? The fetal infection will mainly result in abnormality in the CNS, eye, and other systems. In the CNS, we may have a hydrocephalus, ventriculomegaly, or on the smaller side, we might have a microcephaly as well. In eye, it causes chorioretinitis, which is not detectable by ultrasound. And in other system, we might have a splenomegaly, and this will result in the infant, it will result in developmental delay, jaundice, anemia, pneumonitis. How do we diagnose a fetal infection? So primarily from ultrasound findings, we suspect a fetal infection. Like I said, in CNS, we might have a ventriculomegaly resulting in hydrocephalus. There can be intracranial bleedings or intracranial calcifications, and again we might also have a microcephaly. In abdomen, we have a hepatosplenomegaly, ascites, and there might be intrauterine growth retardation, especially when we are finding the placenta is normal, the Dopplers are normal, and we are having a gross early FGR. We can suspect that there might be an infection at play. Here are the few signs we can see. The first one is an echogenic bowel, then hepatosplenomegaly, hepatic calcifications. These all indicates there might be an infection at play. Okay. And in the cerebral sign, we can see a ventriculomegaly, any intracranial calcifications, and porencephalic cyst, and also microcephaly. Now, these were the signs which helps in, indicating there might be an infection. How do we diagnose it? Basically, we can perform an amniocentesis after 18 weeks, because before 18 weeks we can have a false negative report, okay, because fetal urine production is not adequate at that time. After 18 weeks only it becomes moderate, okay, and also amniocentesis must be delayed for at least 4 weeks after the maternal infection to have a positive torch PCR in the baby, okay. And sensitivity of current molecular test is around 90%. So, but if the fetal, if we do early amniocentesis, the DNA concentration might be low in the amniotic fluid, and so we might have a false negative. Means the baby is affected, but we can have a false negative toxoplasma PSR, okay, PCR. Now coming to the management. Once the maternal toxoplasmosis is confirmed, we must start treatment with spiromycin. Dosage is 1 gram orally thrice a day, and it should be started within 3 weeks of seroconversion till the end of pregnancy. This has to be started once you have a report of positive, okay. Now you perform amniocentesis after 18 weeks, because prior to 18 weeks it's not advisable. After 18 weeks, there might be two scenarios. The fetus is not affected, you have a torch negative, or the fetus is affected, you have a PCR positive. If the PCR is positive, then we will continue the spiromycin for another week and then stop and convert to pyrimycin 50 milligram once a day with sulfadiazine 1 gram thrice a day and folinic acid 50 milligram weekly till delivery. And then treat the infant with this regimen up to 1 year of age, means the first year of the baby's age, okay. And the other scenario, if the the toxoplasma PCR was negative, then I said we will continue the spiromycin treatment till the end of delivery, okay. And another thing is sulfadiazine can cause hemolytic crisis in patient with G6PD deficiency. So we have to test for G6PD before starting the sulfadiazine. And ultrasound follow-up must be done every 4 weeks, focusing on the brain ocular growth assessment. I mean, if we are treating the patient, we should not stop doing the ultrasound. It has to be done. And if even if the ultrasound is normal and we're still suspecting some brain involvement, MRI can be done because it has got higher sensitivity to pick up subtle abnormalities. Noteworthy, as I said, because of often because of early amniocentesis or because there is low fraction of DNA in the amniotic fluid, we may have a PCR negative. But the patient has to be counseled that there is still 30% chances of having a, later sequelae in life in the baby, especially the ocular. I mean, if the USG and the MRI of brain is normal, there still might be a 30% risk of having a significant sequelae in the ocular segment. Now coming to the rubella infection, it's just a small few slides I've prepared on this. The incidence is right now low because of universal rubella vaccination. Infected individuals are infectious 7 days before the appearance of rash to 10 days after the appearance of rash, and the median incubation period is around 14 to 20 days. Like I've discussed in toxoplasma, with increase in gestational age, what did I say regarding the
increases transfer more than 60% at 36 weeks.
So with
increases with the gestational age,
the chance of having an infection will increase, but the chance of severity will decrease. That is for most viral case except for rubella. In rubella the opposite happens. The risk of having a fetal infection will decrease with the gestational age. So it is highest in the first trimester, that is 90%. It is 55% between 12 to 16 weeks, and after 16 weeks means when we go towards the third trimester, it decreases and practically becomes very minimal, okay? But the severity of affection is similar to toxoplasma. Earlier the gestational age, of course the severity will be more. Maternal rubella syndrome is basically most of the patients affected are asymptomatic. Those who have symptoms might have mild symptoms like malaise, headache, cold-like symptoms, and lymphadenopathy. And the rubella rash is usually diffuse, fine, and macropapular, and there is no pruritus. Now, diagnosis of maternal rubella infection. The rubella IgM appears early, but have a high false positive rate. This may be because of cross-reactivity with other virus, long-term persistence of antibody after the vaccination, and because of other auto-antibodies which comes into play. The rubella IgG will appear after a week of onset of the rash. And here again, IgG avidity will help us to determine the timing of the infection. If the avidity is high, that indicates the infection more than 3 months. If it is low, it indicates the infection less than 3 months. Fetal affection may result in miscarriage, stillbirth, and congenital rubella syndrome. In congenital rubella syndrome, most commonly we may have a sensorineural deafness, hearing loss, and learning disability, heart malformation, and congenital cataracts. And less commonly we may have a hepatosplenomegaly, jaundice, thrombocytopenic purpura, anemia, jaundice, and growth retardation again. Some sequelae will again present later after birth. Okay. The problem with rubella is, we have said that in first trimester the infection rate is also very high and the severity is also very high. So if a patient is affected in the first trimester, then we do not need to go for an invasive test. We can directly advise a medical termination of pregnancy. After 16 weeks, if the patient is infected, we can go for a PCR again of the amniotic fluid, and depending on the USD findings, we can discuss each of the cases individually. Okay. Okay. PCR DNA. PCR of the rubella DNA.
কিন্তু ইনফেক্টিভিটি দেখতে হবে
টর্চ ডিএনএ দেখতে পাই সেটাই মানে হ্যাঁ ইনফেক্টিভিটি হবে বাট অ্যাফেকশন ডাজ নট অলওয়েজ কোরিলেট উইথ দ্য দ্যাট ইজ দ্য প্রবলেম
If any patient come with us with history of fever, malaise, we will advise them to torch.
ideally yes
If torture toxoplasma become positive, then we have to start IgM positive.
IgM positive of toxoplasma that's what I said ki it can be positive for a very long time if it is positive then we should go for a spinomycin yep
but I will check that if spinomycin is started তাহলে ওই
we go for a amniocentesis now
18 weeks
yes now if the baby is affected now we get a torch PCR positive I mean toxoplasma PCR positive we change to that regimen yes
বাট যদি আবার নেগেটিভ হয়
তখন স্পাইরোমাইসিন কন্টিনিউ করব থ্রুআউট প্রেগন্যান্সি টিল ডেলিভারি
না যদি অ্যামনিওসেন্টেসিসে নেগেটিভ হয়
হ্যাঁ তখনও তো মা অ্যাফেক্টেড
আচ্ছা
she may still have a chance of infecting the baby later in positive বলতে
করা যায় কি
toxoplasma we do not usually advise termination unless the USG signs are saying ki there is gross abnormality মানে সেখানে USG abnormality অনুযায়ী we will
আর যদি পজিটিভ হয় সেক্ষেত্রে তো স্পাইনোমেসিন চলবে
হ্যাঁ
দুটো ক্ষেত্রে মা পজিটিভ হলে আমরা স্পাইনোমেসিন শুরু করব অ্যামনিওটিক ফ্লুইড টেস্ট নেগেটিভ আসুক বা পজিটিভ আসুক কিছু সেটা পরের বাচ্চার জন্য ডিপেন্ড করে
অ্যামনিওসেন্টেসিস ফার্স্ট ডে মা পজিটিভ এলো স্পাইরোমাইসিন স্টার্ট করে দিলাম 18 উইকসে গিয়ে অ্যামনিওসেন্টেসিস করলাম
বেবি এফেক্টেড কিনা
বেবি এফেক্টেড নেই তখনও পরে এফেক্ট হতে পারে স্পাইরোমাইসিন কন্টিনিউ করবো টিল ডেলিভারি বেবি অলরেডি এফেক্টেড ফার্স্ট এক সপ্তাহ স্পাইরোমাইসিন দেবো দেন উই কনভার্ট টু দ্যাট রেজিমেন টিল 1 year অফ দ্য বেবিজ এজ ঠিক আছে mainly I've discussed the four main if there is both are negative IgG also IgM negative IgG negative the possibilities is that the mother is not affected and she's susceptible to infection or she has just had an infection and there is not seroconversion yet that is one possibility now if there is IgM positive and IgG negative so the problem with toxoplasma is that it can have a lot of false positive IgMs okay and also there is possibility of acute infection these are the two possibilities false positive or a acute infection so we repeat after 2 weeks basically after 2 weeks even if again if we have a similar finding then we considered IgM was false negative if there is 4-fold rise then we consider there is an acute infection by this time the
rise of
IgM and again now the IgG will also start rising the IgG will peak at the 3 months so after that if we find IgM is positive and IgG is equivocal then there is a possibility of acute infection the IgM again may be false positive so now we do a IgG avidity test if the avidity is high it was a past infection mother is immune and IgM is false positive if the IgG have a low avidity now the mother has an acute infection and if both similar for both are positive we have to do IgG avidity in that case